Good evening, everyone. Today's topic is on ophthalmology for Mrcp Part 1, I guess. We have selected few topics which is relevant to the question, maybe around 15. And most of the questions come from these articles only. So let's go through it. First of all, what are the visual emergencies due to vascular cause? Mostly the questions comes from either central retinal artery occlusion or central retinal venous occlusion. So, 84-year-old gentleman complains of loss of vision in one eye since morning. So, sudden onset. He's otherwise asymptomatic. No associated eye pain, especially on movements. So, no associated, I'll say, the inflammation going on. Past medical history includes ischemic heart disease. So, patient is a vasculopath, and they say that on examination, there is no vision, complete loss of vision in the left eye. So it is not a partial vision or one part of the field is not visible, it's a complete loss. And they'll give like this the fundoscopy finding, which shows a red spot with a pale retina. So, what could be the most likely diagnosis based on these symptoms and signs? Is central retinal artery occlusion. Why? Because it's a complete loss of vision, sudden onset, like a vasculopathy, and the retina is pale. You can see in the fundoscope picture the narrowed vessels, a macular infarction probably causing the cherry red spot, and decreased blood supply causing the retina to be pale. So these features suggest painless sudden loss of vision in a vasculopath with the very pertinent fundoscopic features, central retinal artery occlusion. So like any vasculopath, patient will features like hypertension, diabetes. The most important, the fundoscopy finding and sudden loss of vision, painless, and with the fundoscopy. Okay. So early identification is very much necessary because one part of the eye is completely loss of vision. How to treat that depends on the cause. If it is diabetic, hypertensive, stroke kind of feature, then has to be optimized. Otherwise, if it is a vasculitis related to inflammatory disease, then of course the inflammation modulators like steroids and other medication has to be given. Okay. The other vascular emergency is central retinal venous occlusion. So here again the similar kind of feature: 74-year-old elderly gentleman, sudden painless loss of vision, who denies any
Excuse me,
photo.
sir. So sorry to interrupt. Actually, sir, the slides are not moving. It's
Okay.
the slide is freezed in slide two. Yes, sir. Now it's fine.
Okay, maybe slow. Now you can see central retinal
Yes, sir.
venous occlusion. Here also sudden, painless loss of vision may be painful, and there will be floaters and flashes, but not there. So sudden, painless loss of vision. Typical fundoscopic findings are retinal hemorrhages, or typical fundoscopy features are like a stormy sunset sign, what they call, because of the multiple hemorrhages. And if you do fundoscopy, the hemorrhages will be all across the scope. So if it is a part of the scope, then it will be probably branch retinal artery, retinal vein occlusion. But it is throughout the fundoscope finding, then it's a central retinal vein occlusion. Here it will be stormy sunset sign. Okay, the diagnostic hallmark. So it will not be pale retina. It is stormy sunset sign, retinal hemorrhages, and of course there will be swelling and cotton wool spots and tortuous veins. So stormy sunset sign, venous occlusion, sudden painless loss of vision, pale retina with very narrowed vessels, arterial occlusion. Both are painless, sudden loss of vision. In branch retinal vein occlusion, the part of the field will be filled with retinal hemorrhages. Otherwise, in central retinal vein, it is completely the same picture. How to treat? The vasculopath has to be treated with anti-VEGF factors or laser photocoagulation so that you can save some part of the vision. Okay. Of course, it may resolve over a few months, but ultimately you do a ocular CT scan, I'll say, to see what more can be done. So both central retinal artery and venous occlusion are emergency situation. If the patient is coming to your clinic, has to be referred to a ophthalmologist and should be differentiated by the fundoscopic finding. Now coming to the other causes of gradual loss of vision, this is retinitis pigmentosa. So patient will complain of gradually losing the peripheral vision. So key
Mm-hmm.
features of this is gradual progressive vision loss. Two main features: night blindness and progressive tunnel vision, which means the peripheral part of the vision is lost. It's not a sudden vision loss, it's a progressive one. And in any question, the two things must be there: gradually onset tube vision and night blindness. So what is happening in the fundoscopy? Black spicule shaped deposits they will report in the peripheral retina, and the retinal vessels will be gradually attenuating. And if you see the optic disc, they will specifically mention there is a waxy pallor. So it's vascular layer of the main optic disc is gradually slowing down. It may be associated with some congenital symptoms and with that features, but these are not that important. Main issue, the two features you have to remember for the examination purpose: night vision loss and gradually onset peripheral vision loss causing tubular vision. The other causes of vision loss may be like this: 71-year-old gentleman with diabetes and hypertension complaining of light flashes in the right eye. These symptoms have been present for last 2 days only, and more in the peripheral part of the vision. So it's not the whole retina. Some part of the retina is getting affected. So of course the visual acuity will be affected, and the causes may be many because it is a painless loss of vision. So it may be vasculopathy, but vasculopathy usually occurs suddenly. So something else is going on. So you have to see what is happening. Usually in a normal line, the reflections goes to the back of the retina, but here it is falls short. So the distal vision will be affected much more. Like it will happen like a high myopic patients. So probably the vitreous is getting detached. It occurs with advanced age and more in low light. So the floaters, the patient will complain of floaters, which will be like something floating in the vision, or maybe some flashes, like some bright lights will be flashing in the eye. So overall, the visual acuity, especially at night, will be affected, and may complain of, especially in the question, some curtain descending in the vision. So suddenly, some of the vision is obscured by the curtain. So this shows that there is vitreal detachment. Okay. If it is much more bigger, they will complain of this rings, which is called Weiss ring, a big ring color area in the because of the vitreous detachment. Or in the slit lamp examination, it can be found that the vitreous layer is getting detached from the retinal surface. And if you do a optical CT, that is OCT, that will confirm your diagnosis. So next step of diagnosis in a gradually progressive loss of vision with flashes and floaters. Ultimately, you have to confirm with OCT that the vitreous layers are getting detached. So there are few differentials. One is vitreous detachment, which is showing these flashes and floaters. Retinal detachment, which is progressing to the central vision, and vitreous hemorrhage, which is usually occurs very suddenly, so it is sudden loss of vision. But other two are mostly more progressive and slow loss of vision. Ultimately, differentiation must be done with the OCT, which will show a vitreous detachment. So both are mostly emergencies. So you have to refer the patient to ophthalmologist for a laser treatment, and patient has to be educated about gradual loss of vision and taking of the other vasculopathies, and if there is some amount of inflammation that has to be checked. Now coming to the other most common causes of worsening of vision is open angle glaucoma and narrow angle glaucoma, acute one. So here, basically, uh, in the primary open angle glaucoma, what happens is basically resistance to the flow of the aqueous. So there is no narrowing of the angle, but it is increased resistance of the aqueous humor drainage, and it ultimately causes irreversible blindness. So usually the questions comes like with the clinical features and how will be the treatment of it. The pathophysiology is basically, as I said, the trabecular meshwork of the aqueous humor is functionally obstructed. So ultimately, the aqueous humor will accumulate, and that will increase the intraocular pressure more than 24 as per the NICE guideline. More commonly happens in elderly age group or who are myopic and other vasculopathies like diabetic and hypertensive. So a patient who is diabetic, hypertensive, myopic, going to a cinema hall and suddenly having increased pain in the eye, which is gradually progressive for a few days in dark light. And if you
Slides
measure
not moving.
again,
Slides not moving.
so
Slides not moving.
is it in the pathophysiology and risk factors, slide number 18?
Right now, yes, doc, but I don't think it's moving. Yeah, let's try anyway. Yeah.
Okay. So usually the clinical symptoms are insidious onset, visual impairment, and peripheral field of loss of vision. When it is too much and causing accidents and falling down, patient will complain because usually the peripheral loss of vision is gradual onset, not noticed by the patient. Diagnosis is by detection of the peripheral loss of vision and tunnel vision, and of course decrease in the visual acuity, and it ultimately increases the optic cup to disc ratio, which is usually zero point 0.2 to zero point 0.3, but in fundoscopic finding you can see the optic cup to disc ratio is increasing to more than zero point 0.3 up to zero point 0.7 and zero point 0.8 when the usually patient complains about peripheral visual loss and tunnel vision and decrease in the visual acuity. So what we do, we confirm it by fundoscopy, we do intraocular pressure monitoring, slit lamp examination, tonometry, and ultimately gonioscopy, so that you can differentiate it from the narrow angle glaucoma, which is an emergency. So as per the NICE guideline, if the pressure is more than 24 millimeter of mercury, we start with medical therapy after the gonioscopy. First lines are timolol if the patient is not asthmatic, or maybe IV carbonic anhydrase inhibitors. And if that is not also helping, we can call for surgical intervention with trabeculectomy. They'll ask about the side effects of the drugs also, because you have some contraindication in specific populations like avoiding beta blockers in asthmatics, and if the patient is taking some sympathomimetics, so those will not be in the first line of drugs. The first line may be sometimes prostaglandin analogs, which increases the evuscleral outflow. The other one, which can be diagnosed with gonioscopy, the angle is narrowed down, so flow is limited, is acute angle closure glaucoma. Here also the intraocular pressure will be high, and when the patient goes in dark room, pupil dilates, these symptoms increases acutely. So here the patient will complain of pain, and ultimately the eye will be strained, so headache will be there. Of course, there will be some visual disturbances, and the usually the pupil will be non-reactive at that moment. Because the headache, patient may have a nausea, vomiting, so it's all are acute onset in terms of acute angle closure glaucoma. You confirm by tonometry or gonioscopy, and usually we give pilocarpine, timolol, and IV acetocylamine as emergency drug, because unless you lower the intraocular pressure urgently, patient may lose his vision. And definitive therapy is always by laser peripheral iridotomy, so that you decrease the aqueous humor accumulating suddenly. All these patients can cause sudden loss of vision, so acute angular glaucoma has to be referred to a ophthalmologist in an urgent basis. Questions may come
Let's
from.
start moving.
Okay, wait.
Sorry, sir, to interrupt you, as the slides are not moving. So will you please move the slides?
Okay, just wait. It's slide number 31.
So will you please just keep it in the slideshow mode so it should be easy for you, sir.
হ্যালো, হ্যাঁ বলো, হ্যাঁ হ্যাঁ হ্যাঁ, কবে হবে? আচ্ছা আচ্ছা, ঠিক আছে, ওকে ওকে, বলে দিচ্ছি। হ্যাঁ, ঠিক, বলে দিচ্ছি, ওকে, হুম, ঠিক আছে, ঠিক আছে, ওকে 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 ওকে, হুম। So I'm in slide number 31. Hello.
Yes, sir, please continue.
So it is from the eye changes in rheumatoid arthritis. Usually around 25% of patients get this, and there are few changes in the eye with this inflammatory joint disease. Most common is keratoconjunctivitis sicca, which is basically dryness of the eyes. So patient will complain of burning sensation, foreign body feeling because of the decreased lacrimation, and
The
we
slides are
diagnose.
not moving, sir.
Oh God.
We are not. Can we put that on the slideshow so you can just press the next key?
Yeah, it is like that only.
For us, we are still on 31. We probably have seen just 3 slides until now.
It is in slideshow only. Is it moving?
Every time I think manually you do it, it's just moving to the next slide and just staying there. So
What do you want me to do? Why it is happening? Slideshow. Done. Is it showing keratoconjunctivitis sicca?
right now, yes, sir. Yes, right now.
Yes. So I think it's a network problem. So as you know, this is dryness of the eyes along with the inflammation in the joint. So patient with rheumatoid arthritis complaining of foreign body sensation in the eyes, burning sensation and redness, and decreased tear production is usually keratoconjunctivitis sicca. Otherwise, it can be episcleritis or scleritis. Scleritis may be presenting as severe pain and erythema in the eyes with the risk of perforation and can lead to blindness. So that is an emergency. You have to give IV steroids or other NSAIDs or other anti-inflammatory drugs. Episcleritis is a superficial layer, superficial inflammation. It's a painless erythema. So, and it is a self-limiting course. Just pain relief is good enough because it has a good prognosis. Right? Otherwise, it may lead to further severe disease like corneal ulceration, peripheral keratitis, or keratolysis, which has a risk of perforation, but these are pretty rare. Mostly the questions come from either scleritis, differentiating from episcleritis, or keratoconjunctivitis sicca, which is dryness of the eyes. From the medications used in rheumatoid arthritis also, there can be chances of changes in the eye, like steroid-induced early cataracts, chloroquine-induced retinopathy, or maybe steroid-induced elevation in intraocular pressure causing glaucoma. So, if the patient is having medications for rheumatoid arthritis like chloroquine and steroids or maybe other anti-malarial therapy, has to be screened for eye changes on a regular basis. For dry eyes, you give artificial tear. For episcleritis, you just give cool compress. For scleritis, you give systemic steroids, NSAIDs, biologics, even antibiotics. And for corneal diseases, ultimately you may need surgical repair. Now coming to the another important topic, which is Horner syndrome. They'll ask for the diagnosis. So it results from disruption of the sympathetic nerve pathway to the eye, causing miosis, ptosis, enophthalmos, which is sunken eyes, and anhidrosis. That is very important. Small constriction of the pupil, drooping of the eyelids, sunken eyes, and decreased sweating. Depending on it is from the central origin, ganglionic origin, preganglionic or postganglionic origin, symptoms differ and the causes differ. If it is central lesion, the anhidrosis or decreased sweating may be in head, arm, trunk, all over.
Sir, we are seeing only keratoconjunctivitis sicca slide.
So pity. Just listen then. I cannot help because I think it's a network issue.
So,
Yeah. Okay,
Nilanchal
okay.
sir, there's a request. Please just go in the bottom of the side. You can see the slideshow option. So I think there will be, yeah, that one, sir.
Yeah, I've clicked it.
Yeah, sir. I think so. There have been some technical issues, sir.
Can you see the slide of localization based on anhidrosis?
Yeah,
Yes,
yeah.
so now it is. Yeah.
So I'll do it for every slide. Central lesion, anhidrosis in head, arm, and trunk. Preganglionic lesion, anhidrosis will be only limited to face. In the postganglionic lesion, there will be no anhidrosis, so only ptosis, miosis, and enophthalmos. Okay. What could be the causes for central lesion? It may be vascular cause, stroke, maybe inflammatory cause. I'll again share it and see. Multiple sclerosis or maybe tumor or encephalitis. For preganglionic lesions, anhidrosis will be only restricted to the face. It is starts with T, so Pancoast tumor, thyroidectomy, or trauma. For postganglionic lesion, where the nerve is traveling with the carotid artery to reach the eye, artery-related dissection, aneurysm, cavernous sinus thrombosis can be the cause. Okay. So to differentiate between the preganglionic and postganglionic lesions, you can do a hydroxyamphetamine test, which will release the sympathetic norepinephrine. And if it is postganglionic, then of course it will not dilate further. So otherwise, to differentiate between the causes, depending on the level of anhidrosis, you can do CT, MRI, or angiography if it is a vascular lesion and target treatment accordingly. This is another important question. Relative afferent pupillary defect usually comes with a swinging light test. So it's a afferent defect. So if you swing light to one eye, ideally the pupils will dilate, but here it will affect. So it indicates that reduced afferent input and affected eye's retina or optic nerve. So the apparent pathway is either affected by optic neuritis or some other vascular cause. Other common causes can be retinal detachment causing this relative afferent pupillary defect. So usually the question will be 25-year-old young lady coming to the emergency with gradual loss of vision in one eye, progressing over last couple of days, not experiencing any black spots or curtain. So there is no vitreal detachment per se. So it's a neural problem. On examination, there is a pain in the eye. So some inflammation is going on, and there is relative afferent pupillary defect, which means the afferent pathway is affected. So diagnosis is usually optic nerve damage either by inflammation, we call it optic neuritis, or maybe some other cause. It shows the pupillary light reflex. If it is not visible, I'll do it like this. Okay. So the afferent limb of the optic nerve or light pathway starts with retina to optic nerve to lateral geniculate body to the midbrain, and the efferent limb goes there from the midbrain to oculomotor nerve and causing the constriction of the pupil with shining of the lights. So if the apparent pathway of any of the eye, either due to inflammation or some other reason damaged, then the light will not flow. So pupil will be dilated, not constricted. Okay. So in the normal eye, it will constrict with light. In the affected eye, it will be dilating, and even if you shine light in the affected eye, it will not cause causing absent of the constriction reflex. Okay. So optic neuritis, as you know, it can be part of the multiple sclerosis also, causing inflammation of the optic nerve, and usually it can happen with association with diabetes and syphilis or maybe multiple sclerosis. So anti-inflammation or other causes has to be treated. Features of optic neuritis: unilateral loss of vision over few hours or days, poor color discrimination, and maybe sometimes central scotoma or blind spot. If it is as other inflammatory causes, pain is worse on movement, and relative apparent pupillary defect or pupil dilatation with swinging lights is the more prominent sign we can see. Treatment is of the cause, high dose steroids for inflammation, and if the inflammation recedes, the vision will recover in 4 to 6 weeks. MRI features of multiple sclerosis may be associated. Coming to infective cause of this vision loss, which is maybe orbital cellulitis, if it is the infection and inflammation is beyond the orbital plate. If it is, preseptal inflammation or infection, then it will not harm the vision. But orbital cellulitis is a medical emergency with high loss of vision chances and high mortality risk because it can rapidly spread to the brain. So how to predict? You have to check the vaccination status of H influenzae and history of eyelid trauma. So there will be visual acuity loss, eyelid edema, ptosis, severe ocular pain, pain on eye movement. There may be ophthalmoplegia if the extraocular muscles are affected. They are not moving properly, causing diplopia, redness and swelling, along with systemic symptoms like fever, drowsiness, nausea, vomiting, if ultimately it is leading to meningitis. How to differentiate between preseptal cellulitis, which is just inflammation frontal to the orbital septum. It will not affect the visual acuity. It will not cause proptosis. Eye movement will not be restricted. But if it is progressing beyond the orbital septum, ultimately eye movement will be affected. Visual acuity will be affected. There will be significant eyelid edema, and of course, it is a medical emergency, must be treated with IV antibiotics. So, like any other emerging infection, the most common infection is Streptococcus, Staphylococcus, and H. influenzae. So, immediate hospital admission and IV antibiotics has to be started for orbital cellulitis. Coming to the most common question, which comes from diabetic retinopathy, it usually happens in a patient who is poorly controlled diabetic with other vasculopathies with eye changes. So it can progress from mild non-proliferative diabetic retinopathy showing only 1 or 2 microaneurysm in the fundoscopy. In the moderate, it will be not only microaneurysms more than a couple of with blood hemorrhages and hard exudates. In severe non-proliferative diabetic retinopathy, it can be hemorrhages in all 4 quadrants. And finally, if it is proliferative, there will be retinal neovascularization. So, if it is a neovascularization in the question, it has to be a proliferative diabetic retinopathy. Diabetic maculopathy is more important because it involves the macula, but of course, the disease is progressing, so it has to be checked along with sugar control. So, based on the fundoscopic findings, the proliferative versus non-proliferative diabetic retinopathy has to be differentiated, and based on that, you have to treat it. In non-proliferative diabetic retinopathy, laser photocoagulation to prevent progression. In maculopathy, the vascular endothelial growth factors has to be injected like bevacizumab, and in proliferative retinopathy, ultimately the vitreoretinal surgery has to be done, so to be referred to ophthalmologist. What happens in diabetic retinopathy? Of course, like all other eye diseases, visual field reduction, reduction in the night vision, and reduction in the visual acuity. If somebody does a fundoscopy, because of the hemorrhages, it will look red, or maybe it may look like diabetic maculopathy if there is some macular changes are going on. The other differentiations for this is age-related macular degeneration. If it is has to be differentiated with diabetic maculopathy. So the question will come like, is elderly gentleman woman coming for review? She has been recently diagnosed with dry age-related macular degeneration, which is much more common one. What is the strongest risk factor for age-related macular degeneration, which is most common cause of progressive vision loss in UK? So usually elderly lady with risk of smoking, diabetic, hypertensive has a risk of macular degeneration because it involves macula. The vision loss will be very much pertinent, not like peripheral vision loss. She will complain. The drusen formation will be visible in the fundoscopy, and there is confirmatory of age-related macular degeneration. Dry age-related macular degeneration is 90%, and that is much more common. But if it is exudative, the prognosis is very poor. So investigation is of course the slit lamp microscopy or fundoscopy, and ultimately you have to reverse the reversible factors like diabetes, hypertension, etc. The other differential questions may come from acute red eye, with the most common cause will be acute annual closure glaucoma, already discussed previously. Patient will complain of vision loss with severe pain, and the examination will show a semi-dilated pupil. It has to be differentiated from other inflammatory and infective causes, and because it is a ocular emergency. Anterior uveitis will come with the features of inflammation, fever, photophobia, acute onset pain, small fixed oval pupil, and scleritis, we of course will complain of severe pain, worse on movement, tenderness on palpation, and features may be associated with other autoimmune diseases. Non-urgent red eye conditions are
हाँ बोलो
mostly because of
ना ना एक नेक्स्ट
endophthalmitis or subconjunctival hemorrhage. Other less common questions may come from the angioid retinal sticks, which may be associated with other diseases like features of collagen vascular disease like Ehlers-Danlos syndrome, sickle cell anemia, or Paget's disease. So all other associated symptoms will be there, and there will be fundoscopic findings of angioid retinal sticks. If the question comes from optic disc swelling, so usually the fundoscopic finding will be showing features of papilledema. It may be due to central cause or maybe peripheral cause, causing disc merging blurring and elevation of the optic disc. The causes may be space occupying lesion in the brain, malignant hypertension, idiopathic intracranial hypertension or hydrocephalus due to any cause, or it may be secondary to hypercapnia or central venous thrombosis or meningitis. Rarely it may be associated with vitamin A toxicity. So the causes of acute red eye may be emergent causes or maybe less emergent causes. Based on the history and other associated symptoms, you have to differentiate it from other diagnoses. The other questions may come from optic atrophy, which in the fundoscopy will show like bilateral pale disc and gradual vision loss, not like central retinal artery occlusion, which is usually unilateral loss and sudden loss. Here, of course, the diagnostic methods are fundoscopy and finally OCT. Usually happens from degeneration of the retinal ganglion cell actions or the nerves. So the optic nerve or optic disc will show pale and will be confirmatory in fundoscopy. The usual causes are multiple sclerosis, chronic papilledema, or ischemic optic neuropathy, or maybe simply chronic pressure related causes like glaucoma and tumors. It may be due to retinal damage, as already told, like retinitis pigmentosa degeneration, or maybe toxic related to methanol or tobacco amblyopia. But usually the most important fundoscopic findings is pale optic disc and gradual vision loss. There are some congenital causes of optic atrophy also, like Friedreich's ataxia or Leber's hereditary optic neuropathy, but these are rare questions. Mostly the history will tell us gradual progressive vision loss and fundoscopic finding of pale optic disc. Some of the questions may also comes from the type of pupil, like home-study pupil. It will be like unilaterally dilated pupil, poorly reactive to light, but slow to accommodation, and absent deep tendon reflexes. So it may be associated with blepharitis also, the anterior blepharitis or posterior blepharitis, but these are very rare questions. Most of the questions will come from diabetic retinopathy, age-related macular degeneration. Basically, those are more common in their population, along with other vasculopathies like central retinal artery occlusion and central retinal venous occlusion. You have to be very vigilant about the fundoscopic findings and clinical symptoms. Management, most of the time they do not ask, but most questions come from the symptoms, common causes, and fundoscopic finding. If it is blepharitis, then usually it's more a infective cause or inflammatory cause. The signs will be like red eyelid margins, swollen eyelids secondary to conjunctivitis, or maybe some eyelid related problems like causing chalazion and recurrent styes, or maybe causing corneal irritation. But blepharitis is very less commonly asked in MRCP. Other common causes also may come from the viral infection causes. The vesicles are more confirmatory. It will be painful, dermatological involvement, and has to be treated with oral or IV antiviral drugs. It may recur also like any other herpetic infection. So post-herpetic neuralgia treatment, like any other neuropathic pain, they may ask. And of course, if there is a inflammation, it may progress to uveitis, episcleritis, or keratitis. So treatment with antivirals is much more important. Causes of tunnel vision already been discussed. It can be asked, like the causes may be glaucoma, the other associated symptoms may be there. It may be progressive retinitis pigmentosa may be asked, and if it is some associated cause of papilledema, that may also present like tunnel vision. Keratitis will come with a history of trauma or maybe some exposure to some foreign body. It may be some infection, either bacterial, fungal, or viral, and maybe some amount of non-infectious causes like photokeratitis or exposure keratitis, or history of contact lens use. But as they can affect the cornea, the treatments are emergent. So usually the findings will be showing some white blood cells accumulation in the anterior chamber, or focal whitish lesion or inflammatory cell accumulation, and ultimately it will affect the vision. So clouding of the cornea. That's why it's basically emergency, and depending on the infective or non-infective cause, it has to be treated with antibiotics.
Any question regarding the any doubt regarding the slides regarding some topics? We are going to have another session soon, so you can like jot down the points and we'll be happy to help. Thank you.
Sir, one question from Dr.
Yes,
Das.
yes,
Regarding ocular movement,
yes.
uh, give some highlights to saccadic uh, and sporadic saccadic movement and pursuit movement.
Yes, if basically the thing is that if both the eyes moves simultaneously from side to side, okay,
Mm.
as
Yes,
per command, as you pursue the eyes to move from one side to the other side, if there is an inflammatory cause, the movement will be painful. Okay,
yes.
but if the vision loss is not associated with pain, then it is probably unlikely it is an inflammatory cause of vision loss. If it is an inflammatory cause, then the movement will be painful. But if it is non-inflammatory cause of vision loss, the eye movement will not be painful. So any movement, either basically rapid jerky movement, if you ask to look at one of the fingers ask the patient to fix one of the fingers and move your fingers rapidly, and there is no pain, then it is probably non-inflammatory cause, but that will be also affected if there is inflammatory cause. So if the eyes moves rapidly to your fixation, either is a finger or something else, any bright object, slowly, then of course uh, it will be affected. I mean, if it is an inflammatory cause of optic neuritis, the movement, whether it's slow movement or rapid jerky movement, eye movement will be painful. But if it is a non-inflammatory cause, whether slow movement or rapid movement, the eye movements will not be painful.
No, sir. My question is saccadic movement and pursuit movement.
Yeah, but it is related to which cause? That basically, uh, my question, my usually the MRCP questions comes for with the clinical features and fundoscopy features of some diagnosis. Okay,
Hmm.
so the I mean the basically smooth pursuit movement is a slow movement. Saccadic movement is a jerky movement, but ultimately it's eye movement. So if the eye movement is painful, the cause may be inflammatory. So optic neuritis may be a cause. And if the eye movements are not painful, the loss of vision is may not be a inflammatory. So all the cases been discussed or topics been discussed are related to MRCP, right? So there they'll give some clinical features and they'll give some fundoscopic findings. And based on that, you have to differentiate the cause for the diagnosis and maybe what the next line of management. So even if it is saccadic slow movement or uh, uh, pursuit movement, in that case, if the movement is associated with pain, then it's an inflammatory cause. If it is not associated with pain, then it's a non-inflammatory cause. Got my point?
Yes.
Yeah. So all are related to how to deal questions with MRCP. So either it's a vascular cause, central retinal occlusion, venous occlusion, diabetic retinopathy, different grades, age-related macular degeneration. What are the fundoscopic findings? Or maybe angle closure glaucoma or open angle glaucoma. How to differentiate and what is a ocular emergency where a MRCP qualified physician has to defer to ophthalmologist based on the emergent condition. Okay. So here you do not have to examine the patient clinically for part one. You have to just answer the questions, find the diagnosis based on the clinical examination and fundoscopic findings, and what can be the next line of management or how to diagnose.
So, sir, shall we
I'll
take?
share the PPT.
Yes.
Yes, that will help a
Yeah.
lot. Yes. Yeah. Okay.
And the next class we'll be having soon, and the PPT will be given. Please go through the PPT and draw down the questions. So in the next class, it is more easier for us.
Okay.
Thank you.